Okay, good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on hepatitis C virus and hemophilia, health-related quality of life after successful treatment. My name is Samantha, and I'm the Manager of Strategic Communications here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will pose to our speakers after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, March 11th. I want to thank Dr. Kaz Isfordink and Dr. Samantha Gouw for joining us today. I'm going to turn it over to you guys to go ahead and get started.
Thank you, Alison, and my name is Kaz Isfordink, and well, thank you for the invitation to present the results of our study. I'll share my screen now first. So you should be seeing the slides in a moment. Yeah, okay. Yeah, so my name is Kaz Isfordink, and on behalf of my co-authors that you can see below, I would like to present our study entitled Hepatitis C virus in hemophilia, health-related quality of life after successful treatment. And I'm a PhD student and a medical doctor from the Utrecht Medical Center, which is in the Netherlands. These are my disclosures. So I've received research funding from Gilead Sciences, which is not related to this study, for another project. And the Hemophilia in the Netherlands study, which we used the data from, was made possible by a grant from the Dutch Ministry of Health and by the Hemophilia Foundation, the Dutch version, not the NHF. So, as you all will know, that the clotting factor products that were introduced in the second part of the 20th century substantially improved the life expectancy and the quality of life of persons with hemophilia. However, they did come at a cost, because until 1990, many of these clotting factors were contaminated with several viruses. And therefore, the administration of clotting factor products was frequently followed by what was called non-A, non-B hepatitis. And in 1989, it was discovered that the main cause of this non-A, non-B hepatitis was actually the hepatitis C virus. Soon thereafter, the diagnostic testing for this virus became available, and it was discovered that the majority of persons with severe hemophilia were HCV RNA positive. And in the study that is cited here, which was from our center in 1995, almost all persons with severe hemophilia had been infected with this virus. As a result of this HCV epidemic among the community of people with hemophilia, there's been a lot of excess morbidity and liver-related mortality, which is one of the main causes of death among this population. Some background on the natural history of HCV infection. Following infection, there's about 70 to 80% of people who develop a chronic hepatitis. The range that is displayed on this figure is a bit wider, but most studies are between 70 to 80%. The remaining 20 to 30% spontaneously clears the virus, usually within 12 months, and without any risk of developing liver-related complications later on. However, the people that develop a chronic hepatitis can have progressive development of liver fibrosis, which can eventually result in cirrhosis, which is actually scarring of the liver that can lose the function due to this scarring and the loss of cells. And after 20 to 30 years of a chronic hepatitis infection, about 20 to 30% has developed cirrhosis. And of these individuals, a small percentage each year develops liver cancer or hepatocellular carcinoma, which is the medical term, or end-stage liver disease. Well, back to the Dutch persons with hemophilia, the Dutch persons with hemophilia, we know from nationwide studies that the quality of life of persons with hemophilia is lower than the general Dutch population if you look at the physical domains. If you look at the mental domains of quality of life, it's comparable to the general Dutch population. And we know that this quality of life mainly depends on the severity of hemophilia, the age, the orthopedic status, so the joint status, and comorbidities. And one of the main comorbidities that impact quality of life is chronic HCV infection. From a previous study conducted by our research group that was published already in 2005, we know that chronic HCV infection is significantly associated with a decreased quality of life among Dutch persons with hemophilia. And there are several mechanisms in which chronic HCV infection can affect this quality of life. There's the somatic effects, such as fatigue or cirrhosis or extrahepatic manifestations of the viral infection that have an impact on quality of life. There's the psychological effects, like depression is more common in people with chronic HCV infection, and sometimes these individuals can have a mild cognitive impairment. Then there's the social effects, like stigma or knowing that you have the risk of onward transmission. People can experience loneliness in this. And finally, there's the side effects of treatment, especially the previously given back interferon treatment, that has really severe side effects and can impact quality of life. So there's various mechanisms that can impact the quality of life in patients with a chronic HCV infection. Fortunately, there has been great developments in the treatment options for hepatitis C virus infection. As soon after the virus was discovered in 1989, the first interferon treatment became available. However, this was still very ineffective. And during the beginning of the 21st century, we had the PEG interferon combined with ribavirin therapy, which was a bit more effective and cured about 50% of patients who were treated with this regimen. However, it was less effective in the people with the most severe liver damage, with the cirrhosis, and it was less effective in people with the hepatitis C genotype 1, which is the most common among persons with hemophilia. Furthermore, it had to be given for 6 to 12 months and had very severe side effects and several contraindications. Fortunately, currently we have the direct-acting antivirals since a couple of years, and these are all oral drugs that achieve viral clearance. So successful treatment of hepatitis C is usually displayed as SVR, which you can see here, which stands for sustained virological response and actually is a marker of hepatitis C cure. And this DEA treatment results in SVR in over 95% of cases within 2 to 3 months, has limited side effects, and has, again, very high success chance for retreatment after initial failure. So this has really revolutionized the hepatitis C virus treatment landscape. And as a result, fortunately, most persons with hemophilia are now successfully treated for their chronic hepatitis C infection. Well, before I showed you the data on how chronic HCV infection impacts quality of life in persons with hemophilia, but there's no data on the quality of life of these individuals following successful treatment of the hepatitis C virus. So they have lost the virus and the viral infection. However, these individuals have been chronically infected for many decades, which could potentially have left a physical or mental impact even after curation. So we wondered whether the quality of life of these cured individuals was still affected, or whether it was comparable to as if these individuals were never infected. Therefore, the objective of our study was to compare the health-related quality of life between persons with hemophilia, either successfully treated for hepatitis C virus infection or without ever being chronically infected. To find out this research question, we used data from the Hemophilia in the Netherlands study. And the Hemophilia in the Netherlands study is a series of studies that started in the 80s. And this was the 6th edition, conducted in 2018 and 2019. And for this study, all individuals with mild, moderate, or severe congenital hemophilia A or B, who were known at one of the 8 hemophilia treatment centers in the Netherlands, were invited for participation. So it was a nationwide study because all 8 centers that treat patients with hemophilia participated. And this study consisted of 2 parts. There was a survey for all participants, and in this survey, we assessed socio-demographic characteristics and functional outcomes such as quality of life. Additionally, we asked consent to extract data from electronic medical records to reliably assess hemophilia, hepatitis C, and HIV-related data. For the current sub-study, so our study looking at the quality of life of after hepatitis C treatment, we included participants from this HIN study who had available quality of life data from the survey and who had the who additionally approved this medical data record data collection and had available hepatitis C virus data. We excluded individuals who were born after 1991, as the risk of becoming hepatitis C virus infected after this year was considered negligible because of the introduction of safe clotting factor treatment. Furthermore, we excluded individuals who still had an HCV infection and who had antiviral therapy at the moment of the survey. The health-related quality of life was assessed using the RAND36 questionnaire. And this is a questionnaire in Dutch, which is also known as the SF36 questionnaire, which scores quality of life on 8 domains that you can see here. These are physical domains, which include physical functioning and role limitations due to physical problems, vitality and pain, emotional or mental domains such as role limitations due to emotional problems and mental health. There's social functioning and there's general health. And all of these domains, there are several questions, and then a score is given ranging from 0 to 100. What's a really important term in this presentation is the minimally important difference. And the minimally important difference is a threshold at which a difference in the domain score between these groups. So we have 2 groups, both have a score ranging from 0 to 100. And the difference between these groups of 4 points was considered to be the minimally difference that was clinically relevant. And this is based on literature, on quality of life literature, that usually recommends a threshold of a minimally important difference of between 3 to 5 points. And as kind of a pragmatic approach, we just chose the midpoint. So we said the predefined that the minimally important difference was 4 points. So between which groups did we compare these RAND36 domain scores? Well, the main analysis was, as said, between individuals who were successfully treated for their HCV infection and those who never had a chronic HCV infection. And the second group, the one without a chronic HCV infection, did include individuals who spontaneously cleared the virus. So as I said before, about 20 to 30% of individuals spontaneously clear the virus. And we hypothesized that in persons with hemophilia and spontaneous clearance, the current physical and psychological impact of HCV infection on the quality of life at present was very low, since these people were infected about 30 to 40 years ago, and spontaneous clearance usually occurs within 12 months. and it does not result in any liver-related complication. Furthermore, we conducted several sub-analyses. And the first analysis was by excluding individuals with clear HCV infection sequelae. And this was defined as individuals who had advanced liver fibrosis or cirrhosis, so who had liver damage, probably as a result of the hepatitis C virus infection, or who reported themselves to have residual symptoms of the HCV infection or ongoing side effects of previous antiviral therapy. So by excluding this group of individuals with clear sequelae of the cured HCV infection, we wanted to assess whether there was also a difference in quality of life between individuals who don't report any sequelae of the cured infection. The second sub-analysis, we compared individuals who were cured of their chronic infection, specifically with the group of individuals who spontaneously cleared HCV, because these groups were a bit more comparable concerning severity of hemophilia. And finally, the third sub-analysis was within the group of individuals who were successfully treated for their HCV infection. And we hypothesized that there might be an impact on quality of life of the very notorious and burdensome interferon containing treatment. So we compared individuals who were ever treated with interferon versus individuals who were only treated with DEA, which was this newer kind of medication that has very limited side effects. And all the domain scores were compared using an analysis technique called multivariable linear regression. And with this technique, you can adjust for differences in characteristics of groups that might have an impact on quality of life themselves. So, for example, the severity of hemophilia can impact the quality of life. So you can adjust for the impact of severity of hemophilia to more clearly look at the effect of HCV. So we adjusted for severity of hemophilia, age, self-reported joint impairment, and HIV status. Now on to the results. There's in the whole of the Netherlands, there's 1,746, or in 2018, there were 1,746 adult persons with hemophilia who were registered at one of the treatment centers, and all of these were invited to participate in the study. And 37% of these individuals, so 650, both answered the survey and approved this medical record data collection so that we could extract their HCV status. Of this group, several individuals were excluded, for example, because they were born after 1991, because they did not answer all the quality of life questions in the survey. 7 individuals still had a chronic HCV infection, and an additional 5 were receiving antiviral therapy. And we actually had a documented successful treatment of these individuals. However, at the moment of the survey and the health-related quality of life questions, they were still having therapy. In the end, there were 306 individuals who had never had a chronic HCV infection, and 180 individuals who were successfully treated for their hepatitis C virus infection. So these were the groups that we did the main analysis with. Some characteristics of these groups you can see here in this table, and as you can see, the vast majority had hemophilia A, and there was quite a large difference between both groups in terms of severity of hemophilia, with 21% in the group that never had a chronic HCV infection and 67% in the group that is cured. And this is not surprising, because we know that the more severe your hemophilia is, the bigger the chance that you were treated with clotting factor products during the 1980s or 1970s, and thus the bigger the chance that you ever contracted hepatitis C virus infection. So the difference in the severity of hemophilia was also reflected in the joint score. This was a score that people reported themselves for the 8 most commonly affected joints. So the left and the right knees, elbows, ankles, and wrists. And they gave them all a score reflecting functional limitation ranging from 0 to 3, adding up to a total score ranging somewhere between 0 to 24. And as you can see, the group of with the cured hepatitis C virus infection had more joint impairment. Some additional characteristics you can see here. Only a minority of the people included in our study had an HIV infection, which was more common in the cured group. And in this cured group, 12% had advanced liver fibrosis or cirrhosis. So actually damaging of the liver because of the hepatitis C virus infection. And finally, there was the median number of years since successful treatment was 9 years in the cured group. Here you can see the REN36 domain scores of these both groups. So on all 8 domains, there's a score ranging from 0 to 100. And as you can see, these crude scores show large differences between both groups, amply exceeding the MID, or so the minimally important difference threshold of 4 points on all domains. But if we look at these data, we don't know whether this could be caused by the severity differences in severity of hemophilia, or whether actually the hepatitis C virus infection might be the cause of these differences. So as said, we did the multivariable regression to adjust for these confounders. And in this figure, you can see the results. So adjusted for age, HIV, joint status, and hemophilia severity, the adjusted difference remained above this MID threshold on all domains except for pain. So this means that the individuals with a successfully treated hepatitis C virus infection have a significantly lower health-related quality of life on almost all domains, even after adjustment for other factors that impact their quality of life. The largest differences were seen on the domains of general health, role limitations due to the physical problems, and role limitations due to emotional problems. And later on in this webinar, I will return with some thoughts on our interpretation of these results. But first, I would like to continue with the results of some of the sub-analyses that we did, because we did these sub-analyses also to improve our understanding of what these results might mean. First, we took a closer look at the individuals with the HCV infection sequelae. And as said, these were individuals, 41 individuals who either had advanced liver fibrosis or cirrhosis, self-reported residual symptoms of the HCV infection, or self-reported ongoing side effects of previous antiviral therapy. And as you can see here, these groups are relatively comparable regarding severity of hemophilia, but the ones with the infection sequelae had a bit more joint impairment. And if we compare these two groups regarding to the health-related quality of life, we see that there's a large difference in REN36 domain scores on all 8 domains, showing that the health-related quality of life is mainly affected in this group with the obvious HCV infection sequelae. So either the sequelae of that they report themselves, or that is assessed as liver fibrosis. Subsequently, we excluded the individuals with the clear HCV infection sequelae, and we compared the persons who are successfully treated for hepatitis C virus infection without any self-reported sequelae with those who were never chronically infected. And we still saw a difference exceeding this minimally important difference threshold on 3 domains. So general health, role limitations due to physical problems, and role limitations due to emotional problems. So although there was not a very large difference in quality of life between these two groups. And the largest difference was actually between people with clear HCV infection sequelae. We did see that even people who do not report any ongoing symptoms themselves had a lower health-related quality of life. In the second sub-analysis, we compared the individuals who spontaneously cleared the virus with the ones who successfully treated, because these people have a similar, had a similar exposure to hepatitis C, and therefore more comparable regarding severity of hemophilia, which you can also see here. The differences between the severity of hemophilia between these two groups are way smaller than what we saw before. And again, we compared the health-related quality of life, or the RAND36 domain scores between these groups. And as you can see here, the adjusted differences, again, corrected for the same confounders, were still above the MID threshold on 6 out of 8 RAND36 domains. So the results were very comparable to the main analysis, with the only difference that emotional well-being was not significantly different between these groups. So as these groups were more comparable regarding severity of hemophilia, this analysis implies that the differences in RAND36 scores in the main analysis were not just because of these differences in severity of hemophilia, but may also be because of the HCV status of these individuals. Finally, we looked at whether the fact that someone had ever been treated with an interferon-containing regimen impacted quality of life. And there were 135 individuals who ever received this interferon treatment. This included individuals who were unsuccessfully treated. And there were 44 who only received all oral DEA therapy, and 1 individual in wounded treatment type was unknown. And if we compare the quality of life between the 135 individuals ever treated with interferon and the 44 who ever had DEA, we saw very similar RAND36 domain scores. So comparing these groups, the health-related quality of life was really alike. The only difference that we found that exceeded this minimally important difference threshold of 4 points was actually in favor of the interferon group, and was on the domain of energy and fatigue or vitality. And this difference was just exceeding the MID threshold of 4 points. And it's good to mention that these differences, again, are adjusted for age, HIV status, severity of hemophilia, and the joint status. In a sensitivity analysis, we additionally did an adjustment for the presence of cirrhosis, because cirrhosis was more common among individuals who were treated with DEA only. But this additional adjustment for this covariate did not change the outcome. So even with additional adjustment, the difference remained above the threshold on the domain of energy. So, well, as a short resume of all the results that I just showed you, I've showed you that the vast majority of ever HCV infected participants in our study was successfully treated for HCV, with only 7 individuals who were chronically infected remaining in 2018, and hopefully they have received a successful treatment by now as well. So we've made great advances in eliminating hepatitis C virus infection. However, these HCV-cured individuals had lower RAND36 domain scores on all but 1 domain, so on all health-related quality of life domains except for pain, when they're compared with individuals who were never chronically infected. So we cannot say that the health-related quality of life of cured individuals is similar to as if they were never infected. And as a third conclusion, we saw that there were similar health-related quality of life scores between individuals who were ever treated with interferon or who were never treated for interferon. For the final part of this webinar, I would like to discuss our thoughts on how to interpret these results, whether we can find any comparable results in the US population, and some caveats and limitations that are important to mention and apply to our study. So first, our interpretation of the lower RAND36 scores of cured individuals. Well, our thought is that there might be a residual effect of this decades-long chronic infection that continues to affect quality of life in people who did get rid of the virus, but still were infected for 30 or 40 years, which may have had an impact on their social life, on their emotional well-being, or on some physical status. We very clearly saw that the largest impact was in individuals with HCV infection sequelae. So individuals who actually had liver damage because of the virus or who reported ongoing symptoms themselves. However, even after excluding these individuals, we saw that there were differences in health-related quality of life score on 3 out of 8 domains. And finally, what's important to mention that I've said it a couple of times, there were fairly large differences between both groups in terms of severity of hemophilia, both phenotypical as well, because you saw a very large difference in joint impairment. And even though we adjusted for these differences using statistical techniques, there's always a risk of residual confounding. So that means that despite that you adjust for the effect of the difference in severity of hemophilia, you're never sure if you can completely adjust for this effect. However, when we analyzed the more comparable groups of individuals who were successfully treated for their HCV infection and individuals who spontaneously cleared the virus, we still saw an effect on 6 out of 8 domains. So this does imply that it's not just that our results are not just due to residual confounding. So when I was asked to present the results of our study, we thought, well, it might be good to look at whether there are comparable findings in the US hemophilia population. And the data that I did find told me that the most data on health-related quality of life of people with hemophilia in the US is actually in line with the Dutch data. So if you compare people with hemophilia in the US with the general US population, they have lower physical health-related quality of life, but similar mental scores. And like in the Netherlands, there's a lower health-related quality of life for those with HIV or hepatitis C virus infection. However, there were no data in the US population on the health-related quality of life after successful treatment of hepatitis C virus. So yeah, well, it's hard to say and to what extent our results apply to the US population, because it hasn't really been studied specifically. And the study that actually approaches our study the most is one that I would like to mention shortly. And it's this study by the Hemophilia Treatment Centers Network, published in 2017 in Hemophilia, which included data from 135 treatment centers in the US, and actually found that liver disease was not independently associated with quality of life. So quite contrasting to our results. However, this study used a very broad definition of liver disease, and this definition included elevated liver enzymes, so transaminases, and any hepatitis B virus or hepatitis C virus positive serologic status. So the group with liver disease included individuals who had spontaneously cleared the virus. And also, especially for hepatitis B infection, there's a very large group who spontaneously cleared the virus and who does not have any impact of the previous infection on their life. So although this is a very large and well-conducted study, unfortunately, I do not think it's sufficiently detailed to draw any definitive conclusions on people with successfully treated hepatitis C virus infection and their quality of life in the US. Some interpretation on the similar RAN scores between RAN 36 scores between individuals ever treated with the interferon injections or only with the DEA pills. We hypothesized that the individuals who ever received the interferon injections might have a lower quality of life due to the very severe side effects of this treatment, which include fatigue, depression, and even suicidal thoughts. However, we found very similar scores between groups. And actually, this is in line with data from the general hepatitis C virus population, who analyzed the quality of life of people treated with DEA, either with or without interferon, and found very similar outcomes. And in people with hemophilia, there's been a study already more than 10 years ago, where the quality of life of people receiving this interferon treatment was assessed. And in this study, it was seen that there was a very significant decrease of quality of life during the interferon treatment. But as little as 4 weeks after the treatment, the quality of life approached the baseline level again. So although there is a very strong effect on quality of life of this treatment, it's transient for most individuals, fortunately. So actually, these results were not very surprising. Actually, the only difference that we found was in favor of the individuals who were ever treated for interferon. And there are several possible explanations that we have for this finding. It could be because there's a lower prevalence of cirrhosis in the interferon group, although an additional adjustment for the presence of cirrhosis did not change our results. Also, it could be because these people have been successfully treated for longer, but also this has been analyzed. We looked at whether the time since successful treatment was associated with health-related quality of life, and we did not find any significant effect. Another explanation might be that there were some pretty strict selection criteria for individuals who were eligible for the interferon treatment. So there might be some kind of selection bias that the individuals with who received interferon treatment had a higher baseline energy fatigue, and that's because they were eligible. Because of that, they were eligible for the treatment. And finally, it can also be that just because the numbers in this sub-analysis were pretty small, it's just because of some random variation due to the small numbers, and there's not actually a difference between these groups. And what's also important to mention, I think, is that 6% of the individuals who were ever treated with interferon did report residual side effects of this treatment themselves. So despite that we did not find any difference between groups, on the individual level, there still might be an impact of this previously burdensome treatment that we should not disregard. To our knowledge, this is the largest study reporting on quality of life of people with hemophilia successfully treated for hepatitis C virus in a nationwide study. Nonetheless, several limitations and caveats apply to our results that I would like to mention. First, I've said it a couple of times, but we cannot stress it enough. There is a risk of residual confounding, which means that despite adjustment for differences in severity of hemophilia, there might still be an effect of this covariate. Furthermore, although all Dutch people with hemophilia were invited for the study, only 37% responded. And it could well be, we know from quality of life studies, that sometimes the participants are inclined to be a bit more healthy subjects. And we saw in our results that in the study sample, there was 38% with severe hemophilia in total, which is lower than in the Dutch hemophilia population. So this shows that we might have a selection of more healthy subjects. And also there was a very low prevalence of cirrhosis-related complications. So people who ever had liver cancer or any grave complications of cirrhosis. So yeah, we did not really have those in our study. which could impact the interpretability of our results. And also, as said, this minimally important difference threshold was predefined and based on international literature, but still it is a bit of an arbitrary threshold, and the interpretation of the results strongly depends on this threshold. So that's also really important to mention. And some remarks on the interpretability have to be made as well. So our results do not necessarily apply to the population in other countries. They probably apply to the whole of to a large part of the Dutch population because of the nationwide study, but in other countries it might be different. Also, we had very few participants with HIV infection, so we do not know to what extent our results are really pervasive in people living with HIV. And finally, we had no data on race or ethnicity, so we were not able to assess whether that influenced our results. And the questionnaire was in Dutch, so it was probably hard to answer for people with poor Dutch language skills, and therefore they could not easily participate. Well, as a final remark, I would like to bring up some points on what I think we can learn from this study and what you might learn and the implications of our results. So what can you do with these results? I think regarding hemophilia care, it's important to raise awareness for the fact that people might still have an impact of the hepatitis C virus infection that they had for many decades, despite that it has been successfully treated. And for some of these individuals, it might be really beneficial to screen for the need of medical and psychosocial support. I think there should be a special focus on the individuals with cirrhosis, but as we saw, even in individuals without cirrhosis, there still was a difference in quality of life. So I think it's important to raise awareness for this issue, and to see whether we can actually help individuals who still have an impact on quality of life. Regarding research, I think, yeah, it would be really interesting to see whether our results hold in other populations like the US population. And also, I think it would be very good to do an in-depth or qualitative analysis on these limitations in quality of life that might demonstrate more specific limitations and could result in a more tailored diagnostic or treatment or intervention approach. Well, that was what we'd like to tell you. I would like to thank all the individuals who participated in this study. Some of them were present here as well. And of course, all the participants who participated in the study. And yeah, that was what I would like to tell you. Thank you very much for your attention. We will be very happy to answer any questions that you have now, or if you have any questions afterwards, please feel free to contact me by email. You can find my email over here. And thank you, that was it. So I guess back to Alison.
Yeah, thank you so much. That was really wonderful. I'm going to really quickly share my own screen. Wonderful. Okay, I do have several questions for you. The first one is that it's a statement from one of our platforms: fascinating data and work. Thank you. What are your next steps in this research now that you have defined the problem?
Well, thank you. That's a very good question. Unfortunately, I will not be able to continue with the quality of life research in this topic. So because of other projects and my own PhD trajectory is ending. So I really hope that anyone else who reads about this study or even from our research group, reads the recommendations we do for future research and continues with this important subject. So we did some other research in the concerning hepatitis C virus infection in people with hemophilia, but that mainly concerned the more clinical side. So we looked at whether people with a cured HCV infection still developed liver-related complications like hepatocellular carcinoma, but that was no quality of life research. So unfortunately, I won't be able to continue with this research, but I really hope other people will do.
Wonderful, thank you. Okay, another one for you. What barriers do those with HCV face when accessing care and quality treatment?
That's another good question. Thank you. I think that's really depends on the key population, like so the population. So for people with who receive the virus infection through injecting drug use, for example, face really different barriers than individuals with hemophilia. I can't really tell for the US population, but I think the care for people with hemophilia in the Netherlands is pretty well organized. We have very dedicated hemophilia treatment centers, and well, important healthcare costs are pretty low. They're all covered by insurance that everyone has and is affordable. So I think the care for people with hemophilia is well organized, but still things like stigma, it's probably not as bad as 20 years ago. There's still stigma around hepatitis C virus infection, and there's also misconceptions both with persons with hemophilia, but also among physicians about the opportunities of hepatitis C treatment and about what the new treatment means. So yeah, I think it's relatively well organized in the Netherlands, but there's still stigma and there's still misconceptions and a lack of knowledge about treatment options.
Wonderful, thank you. So this kind of pairs with the last question. The statement is, I'm not familiar with the general Dutch population and healthcare system, but in the States, the social determinants of health, like where you live, work, play, the environment one lives in, as well as the accessibility of healthcare services, are thought to play a significant role, possibly over 70% of the impact on health outcomes. So how might the social determinants of health impact the data that you generated?
Yeah, well, thank you for this question and this information. Unfortunately, we were not able to collect a lot of data on social determinants, but for instance, we did collect data on employment status. So we knew whether people were employed or still studying, or whether they were not able to work anymore because of physical impairment, for example. And we analyzed whether that had an effect on quality of life, and it did have a small effect, but the effect was not as great as the effect of HCV status or joint impairment in general. So we saw some effect of social determinants like employment status, but it was not as great as 70%, I think. And I'm not sure, maybe Samantha or Evelien has any additional thoughts.
Yeah, maybe I can start off, and Evelien can add to my comments later. I think that the social determinants of your health status, indeed, also in the Netherlands, adds to the well-being of patients in all the domains that Dr. Isfordink just described. The care system in the Netherlands is, in my view, different from that in the US, because all persons have access to healthcare, and but all patients have to pay a variable amount of their own financial contribution, which ranges from 200, which can be raised on a patient's own initiative, to several hundreds. And so all patients in hemophilia treatment centers have access to psychosocial care and hemophilia treatment. I think an important message that Dr. Isfordink just mentioned is that there should be awareness by patients, in patients and in their healthcare professionals, that this psychosocial support should be offered to patients who may need it. Often maybe adults as well as their caregivers do not think of that patients need extra psychosocial support. And this should be discussed in the consultation room with the physician. And I think that is an important message of this, this study. Do you agree on that, Dr. Mauser?
Yes, for sure, because I know that the last part, that offering psychosocial support, is often forgotten, even in hemophilia treatment centers. But in the Netherlands, we have a great advantage that the distances are small. We're just a small country. So going to the hospital for your treatment and for education is much easier than in countries where the distances are very great or big. So that's why we are probably better off too. And of course, we have very good insurance and support for all people with hemophilia, actually all people in the Netherlands. So that makes a huge difference. Our insurance system is, I guess, much better than in the US and equal for everyone.
Wonderful, thank you.
Yeah, and it stresses actually also with, also we are facing, our country is facing financial problems, and I think we as hemophilia treaters, together with the patient organizations, should advocate for continued very good psychosocial care, and healthcare costs, cuts in that should not impact the psychosocial support and eventually the health outcomes of patients.
Wonderful, thank you all. Okay, we have one more for you. So based upon participant characteristics, what assumptions can we make about those who suffer from HCV and hemophilia, and what collaborative efforts should take place?
I'm not sure if I really understand. So understand the question. So what participant characteristics of individuals with HCV and hemophilia can we, well, could you repeat the question?
Yeah, sure. What assumptions can we make about those who suffer from HCV and hemophilia? I'm assuming that means along the lines of.
Yeah, well, I guess what's an important characteristic or assumption of this population is that about, well, 20 to 30% will have advanced fibrosis or cirrhosis of the liver. So that's a really clear indication of an effect of hepatitis C virus infection that continues even after the curation. So I think that's an important aspect. Yeah, we should also consider that the individuals with hemophilia and HCV are in general individuals with a more severe form of hemophilia, because they had a higher exposure to HCV because they use more clotting factor products. So that's another important characteristics of this population. But I think regarding the quality of life, the impact of advanced fibrosis and cirrhosis is really important. Also because these people are still at risk of developing a liver cancer after curation. So there is still kind of, the risk is lower than before they were treated, but there is still a risk. So there is still kind of a threat that they face regarding the liver.
Wonderful. I actually do have time. I'm sorry.
Can I add something? And
yeah,
one should realize that when you're not treated, the risk of complications is increasing. So to stop this, you should be treated as soon as possible. Because some people are reluctant and say, okay, I have no complaints, but all are, at least for infected for 30 years or longer. So the risk of complications is increasing.
Yeah, so that's a very important addition. Thank you, Dr. Mauser. We really should be stressed that all people with hemophilia and HCV should be offered treatment, because despite their quality of life is not as good as if they were never infected, it's probably still better than when they had the chronic infection. And even though they still face a risk of, some of them still have a risk of developing complications, the risk is way smaller than before the treatment. So it should really be mentioned that everyone should be offered treatment, even those who don't have fibrosis and those who don't experience any symptoms.
Wonderful. Alrighty then. Well, I just want to take a moment to thank all three of you again for joining us this afternoon. We very much so appreciate your time and your expertise. And I'd also like to thank all of the participants for joining in and asking some questions. Please note that this recorded webinar will be available on Friday, March 11th at hemophilia.org under the events tab with all of our archived webinars. Also available in the events tab is our upcoming schedule for our weekly Wednesday webinar series. Thank you again so much for joining us all the way from the Netherlands and from all across the US. I hope you guys have a wonderful evening and afternoon and enjoy your week.
Thank you.
Thank you.